All right, we'll go ahead and get started. Thank you, everyone, again for joining us today. We appreciate everyone taking time out of their busy schedule. We do have a wonderful session to present to you all. The topic is the new executive order on price transparency. And our speaker today is Valerie Barckhoff, who is a principal at Windham Brannon. Again, thank you so much, Valerie, for taking your time out to be with us today, and wanted to hand over everything to you to kick off our event today.
Awesome. Thank you so much. Thank you, everybody, for taking time out today to join to talk about price transparency, the new executive order, and what has been a lot of activity going on over the past few weeks with all of this. Before I jump into the webinar, I wanted to give you a brief overview of my background and a little bit about our firm. I think it's always important to understand the perspective of your speaker. So I actually have over 25 years of revenue cycle experience. I always tell people I actually started before I even entered this field because I worked my way through college as an emergency room registrar and have been very passionate about the revenue cycle and the patient's experience with the revenue cycle ever since then. I began my career working primarily for Deloitte, but with the Big Four. And after about 8 years, made my way over to DeKalb Medical here in Atlanta as their executive director of revenue management and managed care contracting. Hopped over to St. Joseph's Hospital of Atlanta, where I was the vice president of revenue cycle for a few years, and then entered back into consulting because I absolutely love working with clients. I love helping work through transformations and challenging projects. Windham Brannon is one of the oldest and largest CPA firms in Atlanta. We provide tax, audit, and advisory services to clients primarily in the Southeast, but all over the country. I have been with Windham Brannon going on 6 years now and lead their healthcare advisory practice. We are very much a niche healthcare advisory practice that only provides revenue cycle consulting services and work with the majority of hospitals, health systems, and physicians in the Atlanta area. I actually had reached out to a few folks at HFMA as soon as I saw this executive order come out on price transparency because I'm very passionate about it and wanted to start talking about this and what we can do to prepare for it. I wanted to share a little bit about how I prepared so that you know that I actually spent a lot of time trying to get some of the most recent and relevant information. And like I said, new things are coming out daily on this. So even as we close the webinar later this afternoon, please just stay out there and aware of all the different things going on, because I think we're going to see a lot of things happening up until this is finalized in November. But to prepare for this, I actually reached out to different providers across the country to see where they are and how they're preparing. Talked to a lot of technology vendors. We are vendor agnostic here at Windham Brannon. Like to always be able to share what's best in class out there to help you prepare. And most importantly, I actually reached out to some attorneys at some large law firms, particularly attorneys in DC, who are very close in following this and were very instrumental in providing me with some information to prepare for this webinar. So I do want to give credit to Austin and Bird for spending time with me to answer all my questions so that hopefully I can share that information with you. Hopefully all of us are quite aware right now that on June 24th, President Trump signed an executive order on price transparency. The important thing to note is this has been in the works long before any of us saw this executive order on the 24th. So the first question that I wanted to pose so that we can all level set is like, how did we get here? How did we get to the point where the government is now mandating providers be price transparent, and what does that mean? So when we go back, this really all started well back in the early 2000s. The very first high deductible health plan was offered by employers in 2001, but did not gain any more momentum until President George W. Bush signed into law the Medicare Modernization Act. And as part of that Modernization Act, there was a tax law granting tax preferences to funds that were set aside to pay for your out-of-pocket medical expenses. But it had to be conditional on these employees being enrolled in high deductible plans and have a minimum of $1,000 for individuals and $2,000 for families. And the thought, and the school of thought back then, was that by shifting the burden of payment to patients that we would actually see the cost of healthcare go down. I actually vividly remember when all of this was happening because I was at DeKalb, and my CEO at the time was interviewed for an article, and he was a very big advocate of high deductible plans. Again, perspective of the speaker, I've never been a big advocate for high deductible plans. My fear was that patients would start self-denying them care. So he and I had a nice little healthy debate about high deductible plans and what that meant for patients who needed to seek care. As the high deductible plans gained momentum, we saw a lot of employers take advantage of these tax preferences and start offering and moving their employees into high deductible plans. I found some data that shows the percentage of patients that were in high deductible health plans with and without health savings accounts from 2007 to where they were in 2017. So you can see that high deductible health plans with a health savings account in 2007, only 4.2% of employees with employment-based coverage were selecting high deductible health plans, and now in 2017, it was near 19%. Without HSAs, which always had scared me, we had 11% in 2007 and near 25% in 2017. I gathered this information from the CDC, and there's a great article out there. And obviously, you can tell from these trend lines, traditional healthcare is on a significant decline, while high deductible health plans are on a significant rise. I think all of us who work in the revenue cycle have been keenly aware of this transition. We are now having to learn how to collect from the patient, as a large percentage of the money due to us is due from the patient. It is not atypical to get a zero payment remit because the patient still has a deductible that they have not paid towards. So this has created a significant shift and impact to the patient. I've got several slides. I probably could have had hundreds of slides of articles about what this has done to patients. There's been stuff recently in the news about patients with surprise billing or not fully understanding their out-of-pocket. But what we've seen is patients' out-of-pocket cost is up 14% in 2018. So between 2017 and 2018, out-of-pocket expenses rose 14% for inpatient, 12% for out, and 7% for emergency. And this study that I put the source up there, it's Patients on June 25th, 2019, in case anybody wants to go back. And the title was Report of Patients Out-of-Pocket Costs, so that you can go back and look at these articles if you like. But 59% of patients last year had an average out-of-pocket expense of either $501 to $1,000 for a healthcare visit. Now, I could not find this article that I read a couple years ago. But what I had read and wished I could have found is when a patient's out-of-pocket expense hits right around the $200 to $250 mark, it becomes a financial burden for the majority of Americans. What I have learned over my career is when patients and employees are selecting these high deductible health plans, they're not necessarily aware of what they're signing up for, nor are they planning on paying these expenses. And $200 to $250 is right about the time when it becomes a financial burden to them, and they're having to make some difficult decisions about where they use their money. Another article that was out there was from Patient Engagement HIT, and they did a Gallup poll showing that patients are delaying treatment to manage the high out-of-pocket costs. 29% of patients in the United States delayed their health care because of the patient financial responsibility. The people with private insurance saw the biggest spike in the patients who were delaying their care because of cost. And the number of patients with private insurance delaying their care rose from 21% in 2005 to 30% each year since. And I think this is quite alarming for anybody, not just the folks in the revenue cycle. So we have a challenge of billing and collecting the patients for their portion. But the people who have entered our industry with a clinical focus probably do not like to see these statistics that people are delaying care and delaying necessary care. Another article shows that the data for patients' out-of-pocket costs are rising much faster than their insurer's costs. The average patient payments are towards deductibles rose from $151 to $417, and the average patient payments towards coinsurance rose from $149 to $249. So you can see both the deductible and the coinsurance have either come real close to that $250 mark that I mentioned or have exceeded it. So now we've reached the point where the patient's out-of-pockets is becoming a financial burden to these individuals. And as patients take on more costs, what's happening is us as providers are shouldering the burden. This was an interesting article that almost validates the $200 to $250 mark that I read a few years ago, is that as the balance for a patient nears $200, that collectability goes significantly down. We've all seen the ski slope. You know, the best chance of getting the money from the patient is either prior to or during the point of service. As soon as the patient is discharged, the collectability goes down. This particular article put it into different balances. So our small dollar balances, we have a 94% chance of collecting it. We see that start to go down until we hit that large bucket. And that very large bucket, we're going to collect at best 67%. And I would argue we're going to see this metric decrease and deteriorate even further as time goes on. And you can also see the percent sent to collections, which I don't know about you. I'm not a big fan of having to do that to a patient, but they did have a contractual obligation to us. And what percent this impacts our bad debt. Now, the Catalyst for Payment Reform is a group out there that does studies, and they have this report card on price transparency laws. And most states obviously have received a failing grade on price transparency. So you can see here is that Georgia is definitely in the red, and we get an F for price transparency. But what was even more interesting to me doing the research is Georgia Health News reported that Atlanta and Georgia rank below the national average on healthcare prices. Atlanta hospitals rank 43rd out of 53. They gave some, two different statistics out there. One was the average price of normal delivery in Atlanta can range from around $5,800 to near $11,000, and the average price for a mammogram ranges from $89 to $500. And the tagline in the article was, are our healthcare prices not as reasonable as we thought? I have definitely had the luxury of working with hospitals and health systems, not just in Atlanta and the Southeast, but all across the country. And I do see that we have definitely maximized our reimbursement and maximized our rates when we were expecting the majority of the money to be coming from a managed care payer. But now that we're seeing high deductible plans, the ability for some people to get higher rates now shifts that financial burden to the patient. So, we kind of need to rethink our strategy on how we've prioritized what we want to get from our managed care companies and how that is now impacting our patients. And then this article I always bring up is who can forget the Time article called Bitter Pill. I actually took a lot of issues with the way they had written it, but this is the perspective of a large majority of Americans out there, is that we as hospital providers have inconsistent pricing, even in our own departments. I have seen that myself. A lot of organizations have undergone strategic pricing over the years, which is intended to maximize the reimbursement from percentage charge clauses, which starts to make prices seem inconsistent. I have seen the same procedure, depending upon historical utilization, be part of the strategic pricing and get raised, while something that had lower utilization that was not included in the study remained lower. So even within a health system, similar procedures, depending upon the department and how the charge master were set up, are inconsistent. The strategic pricing was intended to improve reimbursement, but we really did confuse a lot of folks. I have seen single images be more expensive than double images, just certain things that don't seem logical and aren't necessarily defensible. But that was a big push in the late 90s and the early 2000s, was to undergo strategic pricing so that we could maximize our reimbursement. And in the process, we as providers have successfully confused patients and regulators. One of the scariest things to me is that oftentimes when you're seeing regulations come down, I'm not necessarily sure if the people who are passing the legislation realize how complicated and complex the revenue cycle is from the moment, the patient enters the system, from how we set up the charge master to all those different nuances with our managed care contracts and billing, et cetera. So we have people who don't fully understand our business passing regulations onto us. So a brief history of the price transparency legislation. So I mentioned back in 2003, we had the Medicare Modernization Act, which really started the trend for high deductible plans, which created this financial burden on patients. What we can say is legislation towards price transparency has begun long before President Trump signed this executive order on the 24th. As part of the Affordable Care Act, Section 2718 of the Affordable Care Act required hospital price transparency. I think I mentioned that I started presenting on price transparency around 2014 because even though it was required for hospitals to become price transparent as part of the Affordable Care Act, we as consultants didn't see much activity. We didn't see people making an effort because of the complexity of it to become price transparent for our patients. So January 1st of 2019, I think we all know this, is that Medicare required us to post our charge master prices online. Again, it was a bit ambiguous. I think some people moved forward with the right intent, knowing that the intent was for patients to be able to go out and try to potentially understand the charge associated with a potential procedure. Now, we all know charge master prices don't really mean anything. That is where I think we as a provider industry started taking offense to the regulations. But we also, some people who could check off that they posted their charge master pricing really just posted gibberish. Some providers posted their internal CDM codes that meant something only to them, along with the pricing. So it did not really meet the intent. And I always go back to what is the intent? As we see in the Affordable Care Act, and as we see with, the 2019 rule for us to publish our charges, the intent is to help patients potentially understand their out-of-pocket so that they can make a decision of whether or not they want to pursue that care with that provider or go to a lower cost provider. So again, because the charge master prices did not accomplish what everybody wanted, we saw a couple things happen. I'm going to talk a little bit about the Trump executive order, but I'm also going to talk about the calendar year 2020 outpatient proposed rule, because they were going along simultaneously. They were not sequential. It's just the timing makes it look sequential. So on June 24th, Trump signed the executive order on price transparency. And on July 29th, the proposed rule for outpatient was published. And within that proposed rule, if you have not looked at it, I would highly suggest everybody get a copy and start looking at it, because this should be the foundation of what we're all preparing for. And it required us to expand charge masters to include our negotiated rates for what they call shoppable services. So I am going to cover a little bit more about what this shoppable services definition is and what CMS is expecting of us. The timelines that are yet to happen is on September 27th. Our public comments are due. I know there is a lot of activity going on with this, and November 2nd is the date when we will all know whether or not this proposed rule becomes final and published. And then the effective date as set forward right now in the proposed rule is January 1st, 2020. What I'm going to talk about right now is speculation. Having talked with different people across the industry, is this requirement in the proposed rule that we share our negotiated rates is a big hang-up for providers. And there is a lot of activity to try to prevent this from moving forward. I don't know if we will, at the end of the day, see negotiated rates being the requirement. But when you talk to people and you think about the fact that price transparency has been in motion now for 9 years, there will be some sort of regulation and requirement for us to help patients understand their out-of-pocket. I personally would like the language to be more of that, is that we need to help the patients understand their out-of-pocket, which takes into consideration their plan, their benefit package, what they've already contributed to their deductibles at that point in time. The proposed rule does not say that. It's pretty simple. It needs your charges and your negotiated rate for a subset of shoppable services. So let's talk about the executive order and what it is right now. So the executive order from the 24th requires the Department of Health and Human Services within 60 days to propose rulemaking that requires hospitals to post charges and negotiated rates for 300 shoppable services. What you will see when you look at the outpatient proposed rule is CMS is mandating 70 services. They've defined 70 services that you need to publicize charges and negotiated rates. It is up to you as a facility to select the remaining 230 services that you want to share charges and negotiated rates. And they have defined what shoppable service means to them. It's something that a patient can schedule in advance. So we don't get to just select anything that we want to publicize that maybe isn't shoppable. We really need to focus on 230 services that we believe patients will go out and potentially shop to try to, understand their out-of-pocket. Now, if of the 70 services, as you go through them, if you do not provide one of those 70 services, you need to still have 300. So you need to document that you're not providing that service at your facility, and then you now need to have 231 of your own hospital-defined shoppable services. As I said before, the effective date is January 1, 2020. So a couple things that they talk about is gross charges. It's pretty much, they've defined it as the hospital charge on your charge master. So no discounts. What do you put on that charge master? And negotiated rates are defined as the charge the hospital has negotiated with that third party. So this is where, hospital executives and lobbyist groups are taking issue with this, is that is competitive information. This is where we're going to see some sticking points as the rule gets finalized. There's only a few exclusions. ASCs, labs, imaging centers, other non-hospital sites of care, and federally owned hospitals do not have to comply with this executive order. So, as part of the executive order, the Department of Treasury had to react to this, and they actually did publish a new notice. So they were directed to consider ways to expand the use and flexibilities of health savings accounts and high deductible health plans as part of this executive order. So this has already come out. I put the issued notice. It's 2019-45, and it's called Additional Preventative Care Benefits Permitted to be Provided by a High Deductible Health Plan under Section 223. I'm actually really excited about this particular part of the executive order. So Section 223 of the code permits eligible individuals to establish their health savings account. You must be covered under a high deductible health plan and have no disqualifying health coverage. So in general, the high deductible health plan couldn't provide benefits for any year until your maximum deductible for that year is satisfied. The question became, what about these chronic illnesses that patients have? They technically weren't considered preventative care. Now, Section 223C2, that's a little typo there, that's a copyright symbol, provides a safe harbor for the absence of a deductible for preventative care. So the Treasury Department and the IRS, in consultation with the Health and Human Services Department, determined that certain medical services received and purchased for chronic conditions should be classified as preventative care for somebody with that chronic condition. So this is an advancement to be able to provide patients services that they need that doesn't force them to meet that high deductible dollar threshold. So what I've put in here is the proposed conditions for individuals diagnosed. So this is in the Department of Treasury notice that, for instance, blood pressure monitoring will now be considered preventative for people diagnosed with hypertension. So we're going to see these services now be covered as preventative care. So I think this is a huge advancement for high deductible health plans. Now, the calendar year 2020 proposed outpatient payment rule that came out in July. I wanted to talk about, I have an article in front of me, it said CMS Price Transparency proposal was in the works months before the Trump executive order. So even though this looks simultaneous or in order, it really was going on simultaneous. So this was presented back to the Office of Management and Budget back in April for review before President Trump ever signed his executive order. So everything you're seeing in the proposed rule was going forward. So VRMA is really trying to get hospitals to develop their own tools to improve price transparency. So this was in the works, and we will see it continue on as an initiative of CMS. So the reporting requirements that they are outlining in the proposed rule related to price transparency is that we need to provide the description of the item or service, the standard charge, our negotiated rate for the payer, and then whatever hospital codes we use for billing, whether that's the CPT, HCPCS, DRG, maybe it's Rev code, we're going to have to go through and define that. So there's some things that we still have to make decisions on how we're going to report this. The information on these 300 shoppable services must be available in a single digital and machine-readable format. The intent there is that they believe companies will develop price transparency tools. So we're going to see a whole lot of activity to try to help patients understand pricing. I'll talk a little bit more later about where we think you should be going with this. I don't think you should just do what's in the proposed rule. We think you should take it a step farther, because just sharing your negotiated rates, if that's where we land at the end of the day, isn't necessarily painting the full picture for the patient. So we've got some recommendations of what you need to be doing. The other requirements as outlined in the proposed rule are that hospitals have discretion on the internet location, but it must be prominently displayed on a publicly available website. I mentioned before, CMS has defined 70 of the shoppable services. That is available in the appendix of the outpatient proposed rule. These are services that can be scheduled by a patient in advance for non-urgent care. The charges must be displayed as a grouping of related ancillary items and services. So this, again, adds a layer of complexity. So it's not just as simple as putting your charge master shoppable items out there with your charge and your negotiated rate. CMS wants you to see what else happens typically for that visit. So looking at these, at first I would start with the 70 shoppable services that CMS has defined. We're now going to have to define hospital specific. What other things have typically been billed in conjunction with that visit, so that we can paint this picture for the patient. So again, a layer of complexity that we all have to figure out how to adhere to. Monitoring methods. So a little ambiguous still in my mind, but they did say that they are going to monitor compliance with the negotiated rates and charge master pricing via complaints made by individuals or other entities. So be careful that maybe competitors or other folks might be out there trying to, shine a light on whether you are or are not complying with this rule. And they're also going to do some self-initiated audits of hospital websites. The maximum penalty is a penalty of $300 per day of being non-compliant. It's not real clear as to when that $300 per day would start, because they said non-compliant hospitals will be given a corrective action plan and an opportunity to come into compliance. So I'm not real clear when I read this as to, is it from January 1st, 2020 that the $300 per day comes into effect, or from when they audit you and give you a corrective action plan? I'm always kind of a belt and suspenders person, saying we may as well take the worst case scenario. I would assume that that penalty is going to go back to January 1st, 2020, if we are non-compliant, because the expectation is for us to be compliant as of January 1. And any penalties that they do assess will be publicized on the CMS website. So before we talk about how do we go about coming into compliance and preparing for something that's not yet final, I wanted to kind of set forward some guiding principles from our perspective at Windham Brannon around price transparency. You may disagree with these, but again, in terms of level setting about how we go about helping organizations become price transparent, I thought it was important. Guiding principle number 1, regardless of what happens in November with the current proposed outpatient rule, price transparency is going to be legislated in some form or fashion. Again, it's been going on for 9 years since the Affordable Care Act mentioned it as hospitals are required to become price transparent. We are not going to see high deductible plans slow anytime soon, and the pressure from patients to the government to force us to become price transparent is going to continue. It may look very different than this proposed rule. This negotiating pricing is really a sticking point, but the people that I've talked to are all in agreement. We will be legislated in some form or fashion to become price transparent. So that is guiding principle number 1. Guiding principle number 2, and this is just from my personal experience of having run the revenue cycle for a long time, is patients do not fully understand their obligations with their managed care plan. A lot of times when we see articles about patients who maybe went out of network or maybe didn't fully understand, a lot of times the initial reaction is the patient should have known better. When you're dealing with a medical condition, I think the statistics are out there is that you're really only hearing 25 to 30% of what's being told to you, and that's about your clinical outcomes and options. They're really not hearing us about your financial component. And I argue that the majority of us aren't necessarily doing an A+ job in sharing that information in a digestible format for our patients. So if we believe that our patients don't fully understand their obligations and that it's partly our responsibility to help them, that would be guiding principle number 2. Guiding principle number 3 would be that providers do have an obligation to help their patients understand their out-of-pocket. When I was at St. Joseph's, we did take this philosophy and said we wanted to make sure that if it was a scheduled elective procedure, that you had information. So even back in the early 2000s to mid-2000s, we were able to put together information on clarity of prices and out-of-pocket potential. So it is our obligation to help them understand. A lot of people will say that we should push this onto the health plans. I argue that if we're going to say you need to go call Blue Cross to understand your out-of-pocket, Blue Cross is not only going to tell them your facility's out-of-pocket expense, they're going to tell the patient your competitors' cheaper, lower out-of-pocket expenses too, and try to redirect them to a lower cost of care. I want to own this. I think it's guiding principle number 3 is that it's our responsibility and we should own it. And how difficult this is, we need to own this and make it part of our processes. Guiding principle 4, patients are demanding and deserve price transparency, particularly on these shoppable services. So we are not going to see them anytime soon just say, no, we don't want this information. So that would be very naive for us to think that patients are going to change their tune. Guiding principle number 5 is that every hospital has the ability to provide patients with estimates for shoppable services. This one people may debate me on, but if you're a large health system, you definitely have the financial means to be able to go out there and get technology that can do this. But even if you're a smaller facility, I argue that where there is a willingness and a desire, you can do Excel spreadsheets and access databases that provide this information as well. So every hospital does have the ability to provide out-of-pocket estimates for shoppable services to their patients. And then guiding principle number 6, which I am a big fan of, is that becoming price transparent is a competitive advantage. If you make it easy for a patient to go out to your website, to be able to understand not just the charge, not just the negotiated rate, but their out-of-pocket, and make it easy for them to access your facility, you will be at a competitive advantage over your competitors. So what next? So hopefully you will find the next piece is useful about what you can do now to start preparing in this ambiguous world. I also recognize that you may not agree with all of the next steps that we have, but even if there's 4 or 5 things that you take away, that would be, really awesome from my perspective. So the first thing, even before we start with the task force, I think we have to look at what these 70 shoppable services are that CMS has put out there. I do believe you need to get a task force together, a very small task force to work on this. And it needs to be driven at the highest level. So for folks on this phone call and webinar, if you don't believe that the executives at the top level appreciate the complexity and the urgency around becoming price transparent, we would be willing to help you tailor this presentation to be able to take and present to your executive team or to a board so that they can start to understand what this is and what this means for your organization. But your executive team your executive team needs to be present on this task force. You need to have revenue cycle leadership because this impacts almost every component, from being able to provide the estimate, to look at charge master pricing that seems out of whack, to making sure that your refund process for patients when we potentially collect too much, all of that stuff needs to be taken into consideration. You're going to need a financial analyst on this team. I'll talk a little bit about building this business case and what this means. You're going to want managed care to be on there and a physician champion. I say keep it simple because too many team members will absolutely prevent progress. You're going to have the same meeting over and over again if you have too many team members. So step 1 of your task force is to establish your own guiding principles. I've set forth what mine are, but again, every organization is different in terms of what they want to do and achieve from price transparency. I put here to consider using the American Hospital Association's principles for price transparency. It's pretty standard. Price transparency should be presented in an easy to access, understandable, and ease of use format for the patient. When we look at hospitals who simply put charge master, numbers out there that didn't mean anything to a patient, they didn't really look at the intent. The intent is to help our patients understand their financial obligations so that they can make a decision. Their guiding principles also include creating common definitions and language describing the hospital pricing. Again, think of it from the patient's perspective. Explains how and why the price of patient care varies. So we need to be able to explain why it may be more expensive to use our facility. Price is one component of this decision, and you'll see me talk about this. There are other components. There is quality of care. There's continuity of care. There's other things that our patients deserve to know before they make a decision. Price is one factor. We need to encourage patients to include price, again, as just one factor and not just focus on price as the only factor. Again, I go back to quality and making sure that we incorporate quality into our price transparency initiatives. And I also believe this last one is that we need to be able to help direct patients to more information on financial counseling. So as they understand their potential out-of-pockets, think about this $200, $250 threshold that now is becoming a burden to them and may cause them to delay care that they need. We need to be able to then route them easily to financial counselors who can help them figure out how to pay us. So I think those were some excellent guiding principles from AHA that I would incorporate if I were back at a provider site. We need to start building the business case now. So if we think about the fact that the final rule is going to come out in November, and we're supposed to be able to comply in January, that is not enough runway for any of us to get prepared. So we have to start preparing as if the proposed rule is going to be the final rule and be effective in January. So you really shouldn't wait, in my opinion. I think a lot of the groundwork that you will do will be valuable even if the proposed rule or the final rule does not include negotiated rates. As I mentioned before, everybody believes that we're going to be regulated in some form or fashion. So moving forward, under the proposed rule is look at your 300 shoppable services. Really look at the 70 that CMS has defined, and then start to determine how you're going to select your 230 hospital-defined shoppable services. I put down some ideas around, what services do you believe are at risk, meaning which ones do people in the public consider a commodity, whether it's imaging, colonoscopy, lab tests. You see the list there. Those are things that people may potentially start to shop around. And you really need to understand your market shift to high deductible plans. So how much of your volume is coming from high deductible plans, and where are you most at risk? Some markets are more aggressive than others, but I found some PwC research is that 85% of employers are going to be increasing employee cost sharing over the next 3 years. So if you're not seeing it where you're at, you will be seeing it. So really looking at this business case. I want to talk about the requirement that we group other related things into these shoppable services. So again, as you look at the 70 defined by CMS in the appendix of the proposed rule, I would argue that this is where your financial analyst is going to need to go back. I would look at your volume and what your volume at risk is. And then the AICPA usually recommends 60 as an appropriate look back in terms of trying to group things. I would say for starting with your high volume under that 70 shoppable services, you need to look at 60 procedures and say what was typically provided in conjunction with CMS's defined shoppable services, so that you can start painting that picture. What other lab tests or imaging procedures or whatnot was part of that? So you really are going to have a lot of analytics, and that's why I would start sooner rather than later, because if the proposed rule becomes the final rule, short runway to do this analysis. If they change it, I still believe this is very valuable in starting to create a truly price transparent environment for your patients. We need to start looking at potential lost revenue. So, we don't know how consumers will behave, but we do know that they will change their buying behaviors, especially millennials and younger buyers of services. They are less loyal to the provider, and they're more worried about their cost of care. So there was some information that I found from a RAND Health Insurance experiment. Regardless of the income group, employees who selected a high deductible plan were 25 to 30% less likely to use services. And so you can assume that 30% of the services that are growing with high deductible plans is potentially at risk of shifting to somebody who can provide it cheaper, whether that's a freestanding imaging, whether that's an ASC who doesn't have to comply with price transparency rules. I would make that assumption that 30% of your business in these shoppable services could be at risk if you aren't easy to use and easy to understand. Your organizational readiness that needs to go in conjunction with these shoppable services. I talked about the charge master earlier. Before we have price transparency, we need price consistency. So really assess your organization's charge master to make sure that you have price consistency, whether that's within a department, across departments, across multiple hospitals. It is not atypical in our heavy merger and acquisition world that we have prices that vary across the organization. So again, this is definitely a resource-intensive exercise to make sure that we understand, are our prices consistent and something that we can defend as it becomes public. I think that's a really important part is, are we consistent and can we defend them? Because it's going to be out there. And I really do think the first people who are going to want to analyze our negotiated rates and our charges is probably going to be the AJC or some local newspaper who wants to, have the next Time Bitter Pill article. So make sure that you don't overlook the charge master and where you are with that as part of your organizational readiness. Determine how consumers are going to access this information. So again, it has to be prominently displayed, but it really is up to you about how. My ideal world is that this is on the very front page of every provider's website where they can go in, access this information, and I challenge providers to go beyond what the proposed rule is. It's not just charges. It's not just negotiated rates. It's the ability for the patient to put in their health plan, their diagnosis, their procedure, and come back with a potential out-of-pocket. Ideally, it links back to what their deductible is with the patient. Again, there is technology out there. Folks like AccuReg have services where they can do this, or you can build some, homegrown Excel spreadsheets, access databases that, through inquiry, you can do that. I would argue that you also need to have easy to access ability to schedule and connect with a financial counselor. So if we're thinking of the patient's perspective, they have a procedure that they've been told they need. They come to our website. We are able to tell them they're out of pocket. We're able to connect them with a financial counselor. The next thing we want them to do is to schedule. So take this beyond just complying with the proposed rule. It's how do you turn this into a competitive advantage and be the easy-to-use provider in your market. So regardless of how you choose to make the information available, make sure your patients can find it easily. I would even argue that you should have some focus groups with patients, whether they know it's you or you're doing focused and blinded. But I would get some patients to come in and talk about what they want to see. We've got our ideas, but at the end of the day, it's the patients who are going to determine whether or not we are easy to use. If it takes them more than 3 or 4 clicks, they're going to stop and they're going to go someplace else. Tools to support price transparency. There's definitely tools out there. I mentioned AccuReg. There's definitely other things in terms of being able to access charges and negotiated rates. If you just define it that way, it's relatively simple to comply. That's just going to be, a spreadsheet. I don't think that's what the patients want. They want to be able to access out-of-pocket care. So the majority of consumers do want an online tool that can tell them how much their health plan is going to pay and how much they're going to be responsible for. Again, the technology's out there. It's a matter of, putting out an RFP if you do have the funds, putting it into your budget and saying this is a priority because we believe it will help us keep volume, potentially grow volume, and it's just the right thing to do for our patients. You can direct them to the health plan websites. There's patient payment estimator tools. The statistic was 44% of Americans would welcome a pricing tool, and as we all publish our information, believe me, it's going to be made. There's going to be apps out there. You're going to want them to access you and not these third-party systems. And they want an easy-to-use website. You're going to really need to look at your policies and procedures as part of this initiative to become price transparent. I wrote down some policies that I thought you would need to evaluate or include. What are your discounts to uninsured patients? We're going to seek scrutiny on our charges, but we also need to be able to say, but we have pricing and discounts for our uninsured patients. What are our discounts to underinsured patients, and what are our financial guidelines? Our charity care policies, our bad debt policies, look at your Medicare bad debt. Refund policies. To me, as we move forward in becoming price transparent, hopefully that means your organization is going to pre-collect or collect at the time of service these out-of-pockets. So that is the ideal state because your collectability goes down the minute the patient is discharged. As you do that, there are going to be chances that you have collected more than the patient owes you because when the claim is finally adjudicated or if the physician gets their claim in before we get our claim in, the deductible has changed. So we need to make sure that our refund policies for our patients are a top priority and that we're on top of that. And then you do need to have a price transparency policy. Most of us probably do not at this point in time because we're just seeing the regulations. But as the rule gets finalized in November, you're going to want to look at that and develop a price transparency policy for your organization. Processes that you need to have or that you need to make updates. So you need to have the ability to provide an out-of-pocket estimation, whether that's via a tool, a web inquiry, a phone call. You need to define that and figure out how that process is going to work when a patient wants to have more information. So if you're choosing to say, we're going to minimally comply and just post our charges and our negotiated rate. You really do need to have that next level of how can a patient ask for an out-of-pocket. If you're not going to proactively push it out there, you need to at least have a path for that patient, because somebody else is going to have that information. And if the patient has to work too hard to get it at your organization, they're going to just bypass you and go to the one that was easy to use. You really want to look at your scheduling and ease of scheduling linked to website. I know some organizations here in Atlanta are moving to self-scheduling for some services, but you want to be able to, as you've got that patient accessing you about a procedure, they're interested in having it there. If they believe that they can afford it, you want to have ease of scheduling. If they are accessing your website because they want to have care there, but they realize that it's more than what they can afford at this time, you want it easy for them to access financial counseling. And it's more than just the charity care application process. Really look at how you've designed financial counseling, in that, is it really there to help you help your patients pay you? That really should be the mindset. It's not just handing out charity care applications. It's not just setting up payment plans. It's really taking this to the next level. Again, there's a lot of cool technology. There's a lot of cool vendors out there who provide services around patient balances. And you're going to want to incorporate that into your processes. This is your opportunity to say, how can we take financial counseling to the next level? Because you don't want these patient responsibilities to become bad debt. You're going to want to look at your point of service and pre-collection processes and policies. You're going to want to look at your patient access accuracy rate, because that all drives, the adjudication of claims and the accurate information that comes out, and making sure that you've got proper processes to do eligibility for payers. So those would be some of the high-level processes that you need to incorporate. As you're moving through, now that you've got your processes defined, training and scripts are essential. This is a very difficult message to deliver. So I mentioned right at the beginning of the presentation that I was a registrar in the emergency room, went to school at University of Kentucky and worked for a hospital there in Lexington. And for 2 years, worked in the ED and having to ask patients for their copays. It is an extraordinarily difficult thing to do. I never underestimate that patient is presenting because they're sick. Now, maybe there's sicker patients coming into our facility, but to them, it's the worst thing happening. And we have not necessarily armed our patient access representatives with the best information. So you really need to consider scripting for the whole organization on what your commitment to price transparency is, your commitment to out-of-pocket estimations, and making sure that it is a disclaimer. It is physician decisions that will change the potential estimate, and that we are making our best estimate on the information that's being provided. But you want to be able to have scripting around that. You want to have scripting around your commitment to help patients with their patient portion. Again, how can you help your patients help them pay you? Look at financial counseling from a different lens and see how can we implement new technology, new processes, new partnerships to really help our patients. And I said, remember, it's more than price. What is the value and what is the brand that you're bringing to the table? So maybe you are going to be more expensive than a person across the street or down the road or even a few miles down the road. You want to have your quality metrics. You want to have your brand front and center. You want to have, your commitment to the community. All these things are going to play into that patient's decisions of whether or not they're going to use you. They may be willing to pay 25% more because you're providing them with quality data and the other provider isn't, or that your quality metrics are better than, and don't have them have to go out there and search themselves. I'm sure we all have had that friend call and say they're looking at rankings, and when you look at the ranking site they're using, it's like a Yelp, and it's not really quality indicators. We want to own our quality numbers, and we want to tell the patients which ones are important and which ones are valuable to us as providers. So my closing thoughts before we open this up to some Q&A. So we're right at the top of the hour. I think we had originally scheduled 90 minutes. I did say, when we were doing this, I didn't think we'd take the full 90, but I wanted to leave it open for questions if there are some. My closing thoughts. So hope is not a strategy. While AHA and other organizations are fighting the executive order and fighting the proposed rule, we need to be prepared for a January 1 go live. And we need to be prepared knowing that some of the effort may not have been needed, but I still think it's valuable. I talk about, what are our 300 shoppable services, particularly those 70 that CMS has defined. What are the typical services that are grouped with that, and how are we going to present it? I think it's really good conversation that is not fruitless, even though there's a high likelihood that negotiated rates is not going to be part of this final rule. Make a commitment to become price transparent. If you don't feel that your organization is there yet, start building that burning platform. Get the word out, ask to present at different meetings, really show why this is important and why it's more than just an executive order that was signed in the summer that some people might think is just a passing fancy. It has been in the works for a very long time. And it's even been in the works before 2010 when the Affordable Care Act. It started back in 2001 with high deductible plans. And if we are following the trends, we would be foolish to not have a commitment as an organization to become price transparent. When you've built your business case, consider piloting it. If you can start piloting even while you're doing other things and doing your analysis, I think you will be better off. So pick your high volume area, start doing that analysis about the grouping of services for that shoppable service, get feedback from patients. How can you potentially roll out access to out-of-pocket, the ability to connect with a financial counselor, the ability to easily schedule, and is your refund process going to work? Get this stuff moving so that you can work out the bugs before we go live. Even if we start now, we have 4 months to prepare. The final rule in November is only going to give us barely 2, and I don't know about you, but a lot of providers tend to shut down the month of December, meaning a lot of people are taking vacation time, and it's really hard to move things. So the more we can do now, the better. Make sure every stakeholder is included. This is not something that can be designed in a box. We need to make sure that we have executive, physician, clinical leadership. Everybody needs to be at the table because this is going to be big and it's going to require a huge organizational commitment and potential investment into this initiative. Share the results of the pilot. What worked well, what didn't work well. Even consider doing some secret shoppers. Call your competitors and try to get price estimates. See how that compares. We're big advocates of secret shopping. We do it on you guys all the time to see who we think is easy to deal with and who's hard to get a price estimate on. And once you're ready, have an outreach strategy. This really could be a market differentiator for you if you've done it well. So rather than, be upset about the price transparency rule, which some organizations are, I would say embrace it. How are we going to become the best at this? How are our patients and our competitors' patients going to see that we are the preferred provider to work with? And when it gets published in the AJC or the local newspaper, we want to be in a favorable light. We don't want to be the ones that people start second guessing our pricing strategies. This really, to me, can be something huge for organizations to use as a competitive advantage. So that being said, I'm kind of going to wrap up. I did want to make 2 offers to the folks who did participate today. One, we would be absolutely willing to tailor this presentation for anybody to take back to use. I'm happy to get on a phone call, edit it, change it so that you can take it back, or we even be willing to come out and do the presentation if you felt necessary to your leadership team or to your revenue cycle team. And if anybody would be interested in us potentially doing a high-level risk assessment of where are you now compared to what the proposed rule says. So how far away are you from being ready? We're also happy to do that. So, we'll share some information after the webinar for anybody who might want to take us up on that offer. But that being said, I'm going to pause. I don't know, Seppi, if anybody had asked any questions in the chat box while I was presenting, or if we want to open it up to see if anybody's interested in asking questions, but I'm happy to do that now.
Absolutely. Thank you so much, Valerie. I don't have any questions in the chat box, but give me a minute and I will unmute everyone. Everyone is unmuted at this time. So the main question that was asked is if the slides would be available and whether the webinar recording would be available. And basically, both of these will be a link on our HFMA website, and we will share the link out to the attendees of where it is. If you, to my recollection, they're all at the same place that it's always been for the past presentations, but the link will be shared out to everyone after this presentation. Valerie, thank you so much for sharing this information and taking the time to be here for our members. Are there any questions from anyone? I do have a question. Here's the question, Valerie. Has the EO, as the EO has been mandated for hospitals, how long do you believe it will be until the order is issued for ambulatory surgery clinics?
You know, that's an excellent question, is that I think it's going to be a couple years before ambulatory surgery centers have to comply with this, or that we'll see that there'll be something mandated for them. But my recommendation, we do work with some ASCs, is that knowing that hospitals are going to become price transparent, and most likely ASCs probably do have better rates because of the lower overhead, that I would go ahead and try to become price transparent myself. But I did ask that question myself about when we would see this come out to ASCs or other entities, and I think it's going to be a good couple years before they have to comply.
And following that thought process, what about physician groups?
Same thing. I think it's going to be a while. You know, I think they're going to focus on the high ticket items in the hospitals. So they're going to focus on us. I think ASCs would be next, and I think we've got probably 5 years before we would see physicians have to be mandated to this. But again, knowing where patients want to go and they want to be able to not be surprised by their out-of-pocket, my recommendation is that everybody assume that this is applicable to them and try to become price transparent for the patients, because it's just, to me, it's the right thing to do. I always say when you're designing your revenue cycle processes, put the patient in the middle, then put the physician, and then figure out how you're going to do all of this. So pretend it's your mom trying to access services, whether it's physicians out of pockets and ASCs or a hospital outpatient department. How can we make this experience better for her?
Right.
I have a question. Can you hear me?
Yes.
How do you think this is going to affect the managed care negotiations with your payers? So, for instance, if I use a shoppable item as an MRI and I'm now negotiating a price with an uninsured patient that's lower than I want to be paid by the insurance companies, how do you think the price transparency is going to affect your future negotiations?
I think that's the big sticking point with everybody, is that this could potentially hurt us. And there's some people who argue it's going to drive prices up. That's why I think there's a lot of people who don't feel that negotiated rates are going to be what's mandated from us. I think if it becomes where we have to provide out-of-pocket estimates, it's less likely to impact our negotiated rates. Now, when it comes to pure self-pay patients, you know, the general rule of thumb is the discount should probably be equal to your, quote, worst paying contract. So you're not giving typically better rates. Now, if you want to incorporate prompt pay discounts to then drive it down lower, you know, that's what I've seen people do, but you do risk payers finding out that you're giving better rates to self-pay patients than them, and that could cause some issues. So I think you'd really need to look at your self-pay discount rates, your prompt pay policies, and things like that to make sure. And I always say, get your compliance department to weigh in on what you decide. But I've seen organizations do it to our self-pay discount is equal to our worst paying contract, but then we overlay some prompt pay discounts to then drive it down more.
What rights do I have as a patient if I see that your MRI is lower than it is negotiated rate and I have a $10,000 deductible? So I don't want to use my insurance. I want to go and get your lower rate and then submit the bill to apply to my deductible. If I use my insurance, it's going to cost me 40% more. How as a hospital
Right.
would we handle?
You know, again, I have to do the disclaimer. Make sure compliance and legal are involved with whatever decisions you do. But I do believe that that is the patient's right to want to choose to not submit it to their insurance company. I think that's a challenge for us as providers because we go out looking for insurance for our patients who present as self-pay, even though it might have been a choice. So I think we're going to have to look at those processes, again, in combination with some guidance from legal and the compliance department on what we are and are not allowed to do. But my personal opinion is that a patient has absolutely every right to do that, and we need to make sure that we look at our processes to comply with that.
All right. Thank you so much. I do not see. Oh, I'm sorry. I think there's one more question, and then I guess we can wrap it up.
Okay.
One moment with me. So Valerie, the question is, with the price transparency requirement, will this improve the patient experience with health facilities providing real-time estimates of their costs for services? It is one thing to look on a website for costs. Hold on, I'm trying to see the rest of the question. It is one thing to look on a website for the cost of service that you're on seeking, and it is even better to consistently get the estimated breakdown before you even get to the doctor.
I absolutely believe when we do this, we can improve the patient's experience. So when I reflect back at my time at St. Joseph's, when we were using Excel spreadsheets for our scheduled elective patients, we were providing them their out-of-pocket. We were looking to see what they'd paid towards their deductible. We were contacting them in advance. And the way we designed it was we scripted, but we wanted the patients to go ahead and pay over the phone and complete the pre-arrival process. And we absolutely had two different processes. We had this red carpet treatment for our patients that were fully financially cleared and had completed the pre-arrival process versus the patients who had not, provided us the information or gone through the financial clearance process. So, and we had even incorporated, again, we made it the service line administrator's decision, but if it was a scheduled elective procedure and the patient had not been contacted or had not actively participated in the financial clearance process, we reached out to the service line administrator to potentially delay the treatment because there were some patients who were just non-compliant in participating. That was very, very rare and was not the intent of what we wanted to do, but we really did want to try to have the best process and red carpet treatment for our patients that improved their experience. We wanted to be able to minimize any potential bad debt or non-payment and things like that. So I do believe as you design this, it should be with how can we improve the patient's experience. And I know that was the last question, Seppi. I think I wanted to kind of close. Oh, there's one more?
Yeah, I actually got one more. I apologize.
Okay.
The question is, do you see any challenges with hospital surprise billing and price transparency?
That's a tough one. I mean, yes, I think there's always issues with surprise billing. I think after we look at shoppable services, we need to go through and say, where have we been at risk of not doing a good job, and the patients out of pockets that are high. I mean, if I was sitting back at a provider site and owned the operations, I would probably try to stratify the patients out of pockets by service offering or DRG or whatever grouping seems logical, and start looking at those high buckets and like, should we have known? Did we know? Was this what we communicated? And start working backwards. But I would look at my own data in terms of what the payers are telling us was the patient's portion at the end of the day, and see how we were doing. So it's kind of a backwards audit, if you will, to say, how can we improve surprise billing? But I do see challenges continue. This price transparency executive order and proposed rule are not going to solve surprise billing issues, I don't believe. I think we're going to have to start looking at that ourselves. Are there any others? Okay,
no,
I was going to, my one last parting thought is, I think everybody needs to stay abreast of any things that are getting pushed out. Like I said, the Department of Treasury pushed out their reaction to the executive order. We're going to see more and more, and as we get closer to that September deadline, we're definitely going to see a lot of information come out about public comments. So I would definitely be watching, Becker's or Modern Healthcare or any of those around that September deadline to see what we can find out in terms of public comments and where we think this final rule is going to go. But again, I would not wait for the final rule in November. I would go ahead and start putting some things in motion to prepare for this. But I want to just say one more time before I turn it back over to Seppi, is to thank everybody for taking time to talk about this. I think, it's an awesome opportunity for us to try to help patients if we look at it from that perspective. So again, the offer is out there. We'll send some information out if anybody wants us to tailor this presentation, do a webinar or come on site to your organization or do a high-level risk assessment for you. We'd be happy to do that. So Seppi, I'll just kick it back over to you.
Well, thank you. Thank you, everyone, for joining today and taking time out of their busy schedule. Thank you, Valerie. Thank you to everyone. I wish everyone a great rest of the day and rest of the week. Thank you, everybody. Bye-bye.
Bye. Thank you.
Thank you.